This is Wusab Michael Park. I'm Chief of Vascular Surgery at the Cleveland Clinic in Abu Dhabi. I've been giving a broad topic that actually is three separate topics. I'll try to do my best at mixing in all three different subjects and highlight what I find of interest of each. And I have nothing to disclose. We'll speak about venous thromboembolic disease and venous stasis. I like to walk back and think about evolution, that the vascular system evolved as a way of mixing the internal contents of an organism once the organism became multicellular. With the ability to mix the nutrients that it ingests, it gives it a competitive advantage. And so the first vascular system actually was the lymphatic system, and still behaves in much the way it did in other lower phyla, and that's with picking up extracellular fluid and mixing it around. With the development of multicellular organisms at higher levels, the differentiation of this into an arterial and venous system allowed for respiration and quicker metabolism. If you look at the heart and the way it circulates, I like to sort of think of it this way. The heart pumps out oxygenated blood into the arteries, and each artery feeds an organ, and that organ manifests a function. And that's the crux of vascular surgery and vascular diseases. The organ that the blood vessels supply and drain must express their function. The organ then circulates out deoxygenated blood into the veins, and it collects and goes back to the heart, go back into the cardiopulmonary system. Edema that's shed by the organ during this capillary phase is picked up by the lymph and drained back into the lymphatic ducts up at the base of the neck. With venous insufficiency, there's edema, and that has a great consequence. The edema of an organ can cause dysfunction of the organ and pain in the organ as the organ is stretched. And that pain is a visceral pain that visceral somatosensory fibers express a very non-focal but very deep pain. People describe it as a bone pain. It's the pain that you get from obstructed small bowel, and dilated veins are exquisitely tender and painful, but it will start as a slow simmering ache, again in the general area of the varicose vein, but it will escalate once a great deal of venous pressure is applied. When an organ swells, that too expresses back as somatosensory visceral pain and organ dysfunction. Stepping back a bit, when veins clot, the original Verhoef's triad still applies. That's with stasis of the blood flow, a relative hypercoagulability induced by inflammation or other conditions, and intimal injury. And so oftentimes you'll only find one or two of those of the triad, but in fact, many conditions you'll be able to identify all three. And when these conditions apply, a DVT forms. You have to remember, blood flow stops in the veins. The veins aren't pushing blood continuously, but rather it's cyclical as the veins really drain into confluences, and then into further higher confluences, and joining up, it finally enters the right atrium and into the right heart. But it's never a smooth, steady flow. So in fact, there's constant stasis, and then the balance of clotting and unclotting, if that goes out of balance, you'll get hypercoagulability. And then there are areas where there are frank intimal injuries that occur. It can be acquired in the sense that you can have a catheter where the catheter tip may be injuring the vein wall. You can have compression where the vein intima gets injured, et cetera, et cetera. And so this centuries-old concept still applies. And so these are the risk factors for DVT that we can find typically in our patients, excluding external compression like thoracic outlet syndrome, May-Thurner syndrome, and popliteal entrapment. The more common risk factors include obesity, cancer, limited mobility. Surgery, and specifically certain types of surgery, are very high risk factors for DVT, including pelvic surgery, abdominal surgery, and orthopedic surgeries with joint replacements. Those constitute some of the highest risks for DVT formation. Anything that creates stasis, and then people with hypercoagulable conditions will get DVT. This is a slide borrowed from one of our vascular medicine folks at the main campus, but we have a hypercoagulable testing panel that we use, and I find it very convenient, but again, something that I find also hard to rattle off. And so these sort of preformed panels allow for some ease of ordering, but in the conditions that are identified on a hypercoagulable workup include both inherited and acquired conditions, including activated protein C resistance and prothrombin gene mutation 2010A and factor V Leiden, fasting plasma homocysteine, antithrombin, protein C, free and total protein S, and factor VIII. And then the acquired hypercoagulabilities, including lupus anticoagulant, anticardiolipin antibodies, beta-2 glycoproteins, and then and the list is there. Who should be tested? That Venn diagram of who should be tested generally varies. If you are for me, if you are unable to elicit a historical causation for DVT, and if the patient has not had other prior DVTs and has no family members who do not who've had DVTs, basically, if they have no family history, there's very little indication for a hypercoagulable workup in an isolated DVT. That said, if the patient has a strong family history of DVT, or it's a female suffering DVT in association with pregnancy or immediate postpartum period, they should get tested. After that, there's a laundry list of relative indications, but you have to remember these tests often include gene screening and are quite expensive, and again, usually not indicated in the general population who shows up with a DVT. Walking this back a bit, so we're going back to the function of the veins. So, and I'm speaking to venous stasis. So, when you have a DVT, you treat with anticoagulation, and we have traditionally used Coumadin / warfarin, but now we have a whole panel of other non-Coumadin anticoagulants that are available that do not require frequent testing of the INR. Why is that? If someone has a DVT, the first line therapy is anticoagulation, and still is for the most part, because it is possible to reopen veins with a combination of anticoagulation, controlling of swelling, and time. But one of the rationales given for early thrombolysis of DVTs was preservation of these valves. And you can see here, why are these valves important? The valves in the veins are critically important for us because we're bipedal, and when we stand on our two legs, the veins are subject to hydrostatic pressures, and to get the blood back up. In fact, we've created peripheral muscle pumps. These sinusoidal veins in the muscles of the leg have a capacitance function. They collect the blood, and then when you walk, it ejects the blood towards the heart, and the valves keep the blood from returning back down the leg. And so this concept is called the calf muscle pump. When you have a DVT, these valves are destroyed. The clot pastes these valves, which are quite delicate and translucent, up against the walls, and when you recanalize, typically you do not reestablish venous function. And so that was a rationale for many of the studies looking at early thrombolysis. Those did not pan out. There is a penalty to be paid for thrombolysis therapy in terms of hemorrhage. But that said, in selected individuals, there is a rationale for it. So you have this calf muscle pump, and again, you can see here, it acts like the heart, and that you have valves and muscles. And when you walk, you have systole. When you're at rest, you have diastole. And so when you're resting, you have blood flow that basically is a filling of the veins, kind of like filling of the bathtub. When you contract, the blood gets pushed towards the heart, and the valves are all oriented typically from superficial to deep, and from inferior to superior, and this keeps the blood flowing in one direction. When people are not moving, whether out of choice, for example, if you're in an airplane seat, not moving for a long period of time, you have basically what I term calf pump asystole, where the blood just doesn't get to move, and that predisposes you to DVT formation. Individuals who are handicapped, and wheelchair bound, people who have joint fixations, for example, ankle fixation, that makes it impossible to pump the blood, and these people are setups for venous hypertension. But even standing in one position for long periods of time, like surgeons do, will also predispose you to venous hypertension, because when you're at rest and standing, you have that hydrostatic column, which is a little more than a meter for most folks, and that's a considerable amount of pressure that exerts an exudative force on the veins and capillaries, resulting in edema and stasis. The final pathway of that is of course the venous ulcer. It is a final common pathway of venous hypertension, where high pressures in the veins resulting in edema results in an ulcer because the skin is unable to heal. Now, if you take the supposition that the skin is never completely whole, but rather always subject to some sort of strain and excoriation and minor cuts throughout the day, in general, you heal nearly instantaneously. You're a self-sealing tire. It's not normal to start leaking edema fluid, but in fact, these individuals will start these ulcers with a blister or a small leak where the skin was itchy. But rather than heal normally, the exudation of edema results in these ulcers that then become colonized and infected, and increase the size of the ulcer, resulting in a large, painful ulcer in this area of the ankle. This is a common location for a venous ulcer. The British call this the gait, or Gaiter region, and that refers to the leggings that are used in soldiers' uniforms. Sometimes we see these venous ulcers actually down to the foot and toes, but it's relatively rare. Actually, it's typically right here at the in the sock zone above the ankle, and that allows you to differentiate venous and ulcers and arterial ulcers, which typically form down at the tip of the toes. And so how do we treat this? You would expect this to heal in a normal, healthy person, but it doesn't, because the normal pathways of wound healing are unbalanced by the presence of edema. Basically, all the cell proteins and cells are swimming in edema fluid and unable to heal normally. And so we'll get to treatments in just a little bit. The CEAP classification of venous disease lets you grade these different stages of venous disease in terms of clinical classification. You can see here, starting with normal all the way out to active ulcer, and everything in between. And so you see spider veins, varicose veins, edema, change in pigmentation of the skin, and ultimately a healed ulcer and an active ulcer here. S refers to symptoms, and A is asymptomatic. The E is etiologic classification, and it can be congenital, primary, and secondary, secondary being post-thrombotic. That's the most common one. The anatomic classification refers to what veins are affected: superficial veins, perforator veins, and deep veins. And pathologic classification refers to what causes the venous hypertension, whether it's reflux, obstruction, both, and a fourth category where no venous pathophysiology is identifiable. In terms of the workup, you have the physical examination looking for edema, swelling, and varicose veins, spider veins. They point you to areas where there is a potential for obstruction and venous hypertension. They give you a level at which the venous hypertension works up to. And so, in fact, the typical location for spider veins and varicose veins is below the knee, and that's where the hydrostatic pressure is the highest for most individuals. When varicose veins occur up in the thigh, you have to think of saphenofemoral reflux or higher in terms of obstructions. For example, like May-Thurner's disease. May-Thurner syndrome, where the iliac vein is compressed by the overlying arteries. The workup involves duplex ultrasound to establish the anatomy and the hemodynamics of the flow. Duplex ultrasound is a very powerful technique in that it's easy, relatively inexpensive, and gives you both anatomy and hemodynamics, whereas the other studies largely give you a static picture. CT venography is a very convenient way of visualizing mostly the veins that are larger than the femoral veins. So anything from the thigh into the torso, chest, and to the shoulders and neck are relatively easily visible. Smaller veins are not. MR venography and CT venography both suffer from that limitation, and also the fact that they require contrast. The injection of contrast into a vein, of course, blows out the diagnostic ability in that particular region, and so these studies have to be carefully timed. Contrast venography is invasive, but can be quite powerful. Most of the time, the contrast venograms are done with the patient completely supine. I had the opportunity to train as a fellow at the Mayo Clinic, and they still had cut film studies and rooms where patients could actually stand and have venograms performed standing, and that I found was a very powerful way of seeing in real time reflux and obstructions as the contrast worked its way up from the foot into the central venous circulation. Of course, you can't do that with most existing equipment, but most carbon tables are able to achieve at least 15 degrees of reverse Trendelenburg, and that's how I do my venographic studies. Is with the effective gravity mixed in. This I think is particularly important in working up varicose veins in the pelvis, also known as pelvic congestion syndrome. Of historical interest, I think most people, most vascular labs may or may not produce this ambulatory venous pressures, air plethysmography, and strain gauge plethysmography. All look at different aspects of venous hypertension, but are technically challenging to achieve regularly. So these other studies are far more easily obtained. The algorithm for working up these patients is fairly straightforward for me. It's to classify the disease and etiology, finding the offending vein, and then treating for pain, edema, and prevention of ulceration. And the fourth ask from the patients typically is also cosmetics. People find it cosmetically displeasing to have spider veins and varicose veins on their legs. Spider veins are cutaneous veins that have dilated from venous hypertension of various causes. And I call them clown balloons in that everyone has subcutaneous veins, but under the right circumstances, these veins blow out like clown balloons. If you have this thin tube, I'm talking about the clown balloons where you shape into various animal shapes. You have to blow really hard, and then all of a sudden it will just pop out and become that sausage-shaped clown balloon. Under the chronic hypertension, these veins will also blow out and form these spider veins, which are coalescences of venous blood under the skin, and typically in fair-skinned individuals, you can see these veins quite easily, and again, they're cosmetically disturbing to many people. The symptomatic part comes from distension of visceral pain fibers that accompany all veins, and in patients who get pain in these veins, they'll describe literally feeling bruised. It looks like a bruise. It feels like a bruise after prolonged standing, and in the worst case scenarios, they feel sharp, severe pain in the area of these spider veins. But also, but mostly they feel tired in their legs. Their legs feel really tired at the end of the day after a prolonged day of work and standing, and so that's the spider veins. The way we treat these is with sclerotherapy after ruling out reflux in the saphenous system and deep system and obstructions either through clinical examination and through sonography. These are easily treated with sclerotherapy by injection of either hypertonic saline or a long chain alcohol through a very small 30 gauge, 27 gauge needle. See here, zap, the vein disappears. When patients show up with these large varicose veins, these are typically the result of long-standing saphenofemoral reflux. This reflux in the saphenous vein drives this process, and there's a strong genetic component. People will describe having other relatives with varicose veins. They find them not only unsightly but also painful. They become warm, hot, and tender with prolonged standing through the day or sitting at a desk. And they when they become hot and swollen, the legs develop edema, and the leaked proteins in the fluid cause a inflammatory response that results in itching. People describe having very swollen, hot, itchy skin that is unbearable, and so they come to seek treatment for this. This patient underwent stab phlebectomies, which is I love talking about old-fashioned surgery because we can also inject these to try to sclerose them. I would argue that sclerosing these veins would be a problem because of the large volume of clot that forms. Drives an inflammatory response that would be quite painful. It's better to just get rid of them, and so we did. This patient had their veins marked while standing with an indelible marker, and in the operating room, basically we plucked them out. One of the more enjoyable operations that I do. It's like pulling earthworms out of the ground. If you've ever done that, the game is to pull the earthworm out whole without splitting it, and with this, the challenge is to get as much of the vein out in one piece without causing it to break off. And we collect these veins out of the body, and the patient feels better. And I'm going to skip over these obsolete operations, but they're of historical interest. So varicose veins are under the skin, but they communicate to the deep system through perforator veins, and these perforator veins can drive the process. So if you just take the varicose veins out, you'll still leave behind perforator veins that can supply venous hypertension to other superficial veins and resume the process. So in fact, people who have spider vein sclerotherapy who come back complaining that these veins returned within a few months, they will typically have a refluxing a perforator vein or if they haven't been worked up, saphenous venous reflux. In the worst case scenario, people will have ulcers over these refluxing veins, and back in the day, we had very little choice except to try to operate on them. You can see under duplex, these perforator veins are visualizable, and you can demonstrate reflux in these perforator veins. The Linton procedure, named after Dr. Linton of Harvard, he undermined the skin under the fascia under an ulcer and divided these communicating veins and achieved wound healing. The SAPS, subfascial endoscopic perforator surgery, was a procedure that back in the day I used to do a lot of until we got better technology. But basically, you can see these perforator veins underneath the fascia of the leg, where you would clip them. You can see here, right underneath this ulcer, the skin healed actually very rapidly. There was still some skin to heal in the back, but that healed eventually with compression. Now, in modern times, we do ultrasound-guided foam sclerotherapy. If you have an ulcer that keeps recurring in the same spot, so typically all these ulcers will heal with compression therapy. That is, getting rid of the edema allows normal wound healing to proceed. But if it recurs, that means that there's probably an offending nidus of venous hypertension, meaning there's a perforator vein of some sort or varicose vein that's feeding the edema, and so now we can do ultrasound guided puncture of these veins and sclerose these veins and get wound healing. This is that diagram of the patient. This patient had those perforator veins closed, and their skin eventually healed, and he stayed healed. This is the anatomy of the superficial veins, and you have the saphenous vein, the lesser saphenous vein in the back, the greater saphenous vein in the side, and you have your deeper veins, the femoral veins. And so these superficial veins coalesce as they go up the leg into these confluences, and then the ultimate confluence for these superficial veins is the saphenofemoral junction. And so much of the venous disease in the legs will arise from problems at the saphenofemoral junction. That's in the easily accessible part of the anatomy, and then in the pelvis and in the inferior vena cava, that's a little bit harder to access. It turns out we've been undertreating that anatomy, and so the patients who have had superficial venous treatment will oftentimes, those who recur will oftentimes find central venous obstructions. The classic operation for saphenous reflux is the saphenous vein stripping. So the saphenous junction is ligated, and the superficial vein, the greater saphenous vein, is then stripped. It's an operation that I still do. In this day and age, with all the minimally invasive techniques, I find that this operation is pretty minimally invasive. It involves a small incision, not this gaping huge incision that was drawn for illustration, but rather about a 3 to 4 centimeter incision in the groin is sufficient to expose the saphenofemoral junction, and this small 2 centimeter incision down at the knee. I try to stay at the knee or above for the strippings, and this results in no recurrence. The vein is gone. Many of the other newer techniques suffer from recurrence, which I find very disappointing, because when these veins recur after, for example, laser therapy or radiofrequency ablation, all the valves are broken, and there's even more reflux, I find, and the patients are quite upset that they had undergone a procedure and then it came back. So this works, and I tell them they will probably form more veins decades down the road, because they if they have the tendency, it seems to recur, but it's not going to happen next year or within 5 years, and so many will choose the vein stripping, and they do quite well with this. Endovenous laser therapy is a procedure that has been popular for the past several decades. Involves using a laser heat energy to close these veins. This illustration shows the concept that the cavitation bubbles carry heat energy to the perforators. So the perforator veins also will close if done properly. With good withdrawal. The problem with this is that you need to inject a tumescent anesthesia, which is basically large volumes of cold saline with lidocaine around the vein to act as a heat sink to the laser. That's a critical thing to do in thin individuals. You can develop third-degree burns, and it can be quite painful to hit a patch of vein that hasn't been well anesthetized with this. But when done well, and it can be reliable and minimally invasive. The other problem attached to this is the saphenous nerve can be injured with the burn, resulting in bothersome saphenous neuralgia that can last several weeks to months after the procedure. The flip side of this, I warn the patients that they may develop a permanent medial sensory loss with burning of the saphenous nerve, and if patients aren't warned about that, they become quite concerned. Reassure them that the subjective feeling of sensation eventually does come back as your brain remaps itself. So it doesn't bother, but at least for the perioperative period, there may be a neuralgia or paresthesia related to this. This is the EVLT procedure done in the office under ultrasound guidance. The vein is accessed and tumescent anesthesia is delivered, and the patient goes home that same day. We're going to change speeds a little bit to central venous interventions. So let's say we've got patients who have ulcers that occur and then recur despite having ablation of their saphenous systems and resection of any varicose veins, sclerotherapy. These people, when you investigate them, oftentimes will have a central venous obstruction, whether it's just an isolated obstruction of the iliac vein or obstruction of the vena cava. And it's hard to know what caused it. Many individuals will show up with being told that they had agenesis of their inferior vena cava, and typically that's not the case. It's a atrophy of the vena cava and iliac veins from a long-standing thrombosis. The test is being able to pass a wire easily through the anatomic tract of the closed inferior vena cava. Nowadays, with the presence of catheters and surgeries, and also inferior vena cava filters that are often left way past their retrieval dates. Either typically somebody forgets, either the patient or the physicians. And so they're left in past their recommended retrieval dates. You get these acquired inferior vena caval obstructions that result in chronic venous insufficiency. We treat these with interventions once if they're chronic. So if you're able to pass a wire, we can treat these with large wall stents. In the U.S., we don't have stents available yet that are specifically designed for the veins. In Europe, and I have access to CE mark products. We do have access to stents designed specifically for deployment in the veins. Here, I have a large wall stent being deployed across an occluded IVC filter. And so you can see you have this situation on the left with the patient having a chronic iliocaval obstruction, leg edema, and recurrent ulceration, mostly on the left leg. After intervention, you have restoration of flow into the iliocaval system, and the patency of this is quite good. This venogram doesn't show it very well, but you can see collaterals here across the midline of the pelvis. In late phases of these pictures will typically show abundant abdominal wall and pelvic collaterals that act to drain the legs. And the analogy I use is I used to own a 100-year-old house in Shaker Heights before I moved to Abu Dhabi, and one of the biggest pains of that house was drainage. When we had heavy spring rains, the backyard would flood because it had subsided over the decades, and so the various different redundant drainage systems were incapacitated or poorly functional, and so you had was basically the equivalent of edema on your lawn. So what drains a house? It's a combination of downspouts, gutters, and low areas. And so same thing with your body. The vein enters your leg through the arteries, has to leave somehow, and that blood will find a path, either through a collateral or through the main drainage system, or through or through the skin. And if you can't, you get edema and swelling and pain. If you have a situation where you can't open up a blood vessel, it's chronically occluded, nowadays we find chronically occluded stents that we can't recanalize, and you get venous hypertension. It is also possible to perform venous bypasses. They are technically challenging insofar as they don't tolerate technical errors very well. You get a clot. But there's typically enough venous hypertension to drive emptying. And so, again, I mentioned that venous flow is not continuous, but rather a series of phasic forward flow, back flow. And that has to do with the fact that respiration and intracavitary pressures of the thorax and abdomen will halt flow and drive backflow if there are no valves. So the Palma procedure takes the saphenous vein of one leg and uses it to bridge across the midline to an open central vein. And you orient the valves in such a way that reflux doesn't occur. And conceptually speaking, you're creating a large collateral. It's enough typically to relieve the venous hypertension and edema for a period of time, allowing patients to then fit into non-custom-made stockings and have a better quality of life. Eventually, these will likely close. The patency rates on these is not terribly great, but if you have someone with severe edema and convert them to someone with mild to moderate edema, they're able to function better and grow their collaterals if the pulmonary bypass closes slowly over time. There are other ways to repair deep venous reflux, including valve transplants. There's variable results around the world literature on these. In the U.S. experience, the outcomes have been poor. The problem is when this fail, you get another DVT, and so in someone who's had a previous DVT, another DVT actually makes things worse. Artificial valves have been tried. This is like a venous equivalent of a TAVR valve that's deployed over a wire through a catheter. These almost uniformly have failed. One, because they're balloon expandable and typically highly mobile regions, and the native natural venous valves are basically have no mass. They are very few cell layers thick, but they have incredible tensile strength. So those two characteristics allow them to open and shut very rapidly. And that property by itself prevents thrombus formation. It's also aligned with endothelium, which has thrombolytic properties. These artificial valves do not have such an advantage, and typically thrombosis, and the trials reflected that. Occasionally, you'll find a valve that is refluxing due to distension of the vein through upstream obstruction or reflux, and these can be repaired much in the way that mitral valves can be repaired. Again, it seems to work only in the hands of some very select few surgeons who are bold enough to try it and persevere through failure. I have an ongoing conversation with Dr. Tripathi in India, who has experience with this, and again, we run across occasional patients who have the deep venous reflux, who have venous insufficiency, who want better options than stockings for life. These are various procedures done and conceived to repair veins, and also there's a thing which I don't have illustrated called a neo-valve procedure that you create a valve using native tissues. You can see here a valvuloplasty procedure showing a competent valve that was created from an incompetent one. I don't have the previous one's not showing up, but you get the idea. Multidisciplinary wound care. We treat our patients with wounds in a multidisciplinary setting involving a combination of wound care nursing specialists, podiatrists, infectious disease experts, and vascular surgeons and vascular specialists. That said, with the venous ulcers, it's the guiding principle is getting rid of the edema and decontaminating the wound. So the wound needs to be decontaminated and compressed, in a way that allows the wound to then start normal healing in the absence of edema. Dr. Una, the creator of the Una boot, saw this in the 19th century when he observed the sisters in the convents massaging edema of patients' legs and wrapping these legs with linen cloths. He added to those linen wrappings zinc oxide paste, which has a bacteriostatic property. It's fallen out of favor because the patients really don't like it. If left on too long, it does get smell bad. It feels slimy, and so patients often don't tolerate it. It really needs to be changed at least once a week, maybe twice a week. The problem with it in the U.S. is that oftentimes an Una boot change is not billed and not reimbursed, but a multi-layer dressing is. The multi-layer dressing illustrated below is a 3 or 4 layer dressing that has absorption and compression, but without any medication. And so the medication comes in the form of these salves, balms, and unguents, which I have above. This is an older picture, but much of the products that we use haven't changed that much over time. Every year we get some new agent that is genetically derived and grown in a vat. So it's supposed to provide growth hormones, but at the end it doesn't provide any added benefit to the tried and true methods of compression and decontamination. This patient had a very angry ulcer here. This is from actually 15 years ago. 17 years ago, when I first started, this ulcer failed to heal despite multiple different treatments, and so the patient came to me. I merely applied an Una boot, and after a while, this eventually healed. In this day and age, in 2019, I would probably also do an ultrasound, and finding any veins, I would also perform ultrasound-guided sclerotherapy of this. But that said, in my experience, over 90% of these wounds will heal with compression therapy. The recurrence is a different matter. This final slide in this panel of slides is this gentleman who showed up right before I left for Abu Dhabi. His doctors referred him because they were really worried about this. Turns out this patient has had these varicose veins since World War II. He looks younger than his age, and he had these varicose veins when he was in the German army. He defected over Austria. At the end of the war, he dropped his weapons and surrendered, and eventually emigrated to the U.S. And grew up in the U.S. and became a U.S. citizen. He has no symptoms whatsoever in these veins. We had a long discussion about compression therapy, but in the absence of symptoms and his sort of nonplussed state of being referred to a vascular surgeon for something he's had for decades, we both agreed to just leave these completely alone because they didn't hurt him. And so in the absence of pain, in the absence of edema, and in the absence of ulcers, I felt very unpressed to do anything. We're often asked to do things for little gain for the patient. In conclusion, intervention for the treatment of end-stage post-thrombotic syndrome is less effective than prevention. And so that's the thing. We can do a lot of stuff, but at the end, prevention, wearing of stockings, avoiding edema, avoiding DVT, those are very important. And compression treatment of ulcers consistently effective at healing ulcers, but not preventing recurrence. And unfortunately, that's true. These ulcers recur at a rate of 40, 50%. The current impetus is finding out central venous obstructive causes of venous hypertension. Focal venous hypertension in the form of varicose vein sclerotherapy may suggest ulcers have a local regional etiology. That's a fancy way of saying that these ulcers, when they happen in the same spot over and over, may also have a varicose vein or a perforated vein underneath that need to be treated. Functionally restorative procedures are not widely used. These are the vein procedures, valve transplants and valve restoration procedures I've mentioned. And again, it doesn't seem to work except in very few hands. And so I would caution you before embarking on that. Central venous occlusions should be treated with intervention. And we're going to expand on that in the next chapter. The principle is to treat patients with the least invasive and most effective therapy usually, and that's usually compression, not lasers, not much of anything else. At the end, compliance with compression is the most effective long-term therapy. But short-term patients' edema can be significantly reduced with relief of reflux or central venous obstructions. Workup involves examination and identification of occlusions, collateralizations, and valvular reflux, best done with duplex ultrasound with a dedicated lab personnel. So, stepping back to DVTs again, they're very common and are a leading cause of death and disability in the U.S. We discussed this earlier, but this is the end-stage sequela of venous hypertension. Again, the changes in the skin, the ulceration. In the arterial side, we're often taught to think about inflow, conduit, and outflow. On the venous side, it doesn't work the same way in that you're looking at drainage point to drainage point, and you don't have the big pressure heads that drive blood flow. Rather, the concept that I like to use is the series of confluences, these major confluences at the groin, at the two iliac veins into the vena cava, the addition of the renal veins and the hepatic veins, and to the ultimate confluence, which is the superior and inferior vena cava into the right atrium. Those are the major confluences of the body. Understanding the anatomy of your venous drainage is important to make a plan to treat. The tests involve venous duplex, CT venography, and MR venography, and we discuss compression. When we treat central venous obstructions, the Cleveland Clinic experience was published several years ago, 28 patients with IVC stenting and iliac venous stenting for obstruction. And in this small number of patients, it seems that the central venous intervention in the IVC and iliac veins seems to be quite robust, and that's been my experience as well. It's even those who've had come to me with the history of agenesis of the vena cava and likely closure for decades. When you open them up to the appropriate size, and these are quite large, the vena cava being over 20 millimeters in size at the end of the procedure, the iliac veins 16 and 18 millimeters at the common iliac veins, and over 14 millimeters at the external iliac into the common femoral veins. That size makes a difference. Just going through one of these patients, we have a patient with hypercoagulability after pregnancy and pelvic congestion, feeling of heaviness for years after pregnancy. We worked her up with a duplex ultrasound and was able to show that the vena cava was out. You can see here we couldn't see the vena cava. They have the aorta, and what looks like a small vein here, it turns out to be a collateral. The IVC itself is occluded. And the collaterals do show a high degree of flow relative to what one would expect. The pelvic collaterals, there were numerous pelvic collaterals seen on this ultrasound, and I built this composite picture of all the color flow images to show what we saw. You see the occluded IVC on this ultrasound using the curved probe and the large collateral vein along the side, and you can see the iliac veins themselves are open on either side. You can see all the way up to the suprarenal IVC, which is also open. The renal veins are open, and so again, we speak about confluences. The femoral confluence is open, and that's a key point. That needs to be connected to the suprarenal IVC for this revascularization that's planned to work. With venography, you can see that there's a lot of paraspinal collateralization with occlusion of the central veins. The key point of this is getting the wire to cross in the native system. It's easy to leave and extravasate. The key point about this technically is that on the venous side, the pressures are lower, and so the consequences of perforation are much lower. In fact, there are very little consequences in the peripheral venous system because of the low pressure nature of the system. And so we get the venogram, but you see the wires are in the position that you want to be, and so we first balloon, open the track, and then lay in the IVC stent. This turned out to be a 24 millimeter, I believe, wall stent, telescoping in the right iliac stents and the left iliac stents in a kissing fashion in there. And we've reopened the veins. This is the confluence to confluence concept for me that I use to try to it recapitulates the inflow conduit and outflow idea. And you see the confluence that I connect that work is from the common femoral vein upwards. The interventions in the leg, in the deep femoral vein, the popliteal vein, they do not seem to have good longevity because, again, these are low flow systems and are prone to early thrombosis. Natural recanalization is a process that we rely on when we anticoagulate patients. It changes the balance towards anticoagulation and favors fibrinolysis. And so the patients with walking and normal activity eventually open up channels in these occluded veins. Sometimes there can be quite serpiginous and multiple small routes inside the veins. Other times the whole vein can open quite nicely, but again, these veins lack the valves, and so can cause venous hypertension. You can get durable results with central venous interventions, and you really need to have the femoral venous confluence open to get good results. Again, being patient with anticoagulation, oftentimes patients will do fine without intervening necessarily. But again, these interventions are reserved for when people develop complications, including pain, severe edema, and ulceration. I'll switch gears again to hemodialysis access to finish off the third leg of this marathon of a talk. Dialysis access, I believe, is one of the most important functions that I perform. I like to say the most important blood vessel in the body of a patient with renal failure is their dialysis access fistula. And why is that? Their lives depend on it. You can see here the basic anatomy of the left arm, which is the typical area we make these fistulas. You have the axillary and brachial artery, which divides into the ulnar and radial arteries, and then the veins, the cephalic vein along the snuff box of the wrist and on the lateral forearm and up the arm, and the antecubital vein connecting to the basilic system on the medial side of the arm, and the brachial veins which accompany the brachial artery. All these veins are potential candidates for outflow with an inflow target from either the radial or brachial artery. The Fistula First campaign started in the early aughts when it was noticed that the majority of patients were getting dialyzed either through catheters or grafts, which have inferior patency and higher morbidity and mortality, especially with the catheters. And so a campaign started, and eventually it became what is now a quality metric for dialysis centers and vascular centers, and that the percentage of patients getting dialyzed who have fistula is considered a key quality metric for your dialysis center and for your vascular program. The timing of fistula creation, the fistula should be planned well before the need for dialysis, and that these typically take anywhere from 2 to 6 months to mature properly with any adjunctive procedures to try to optimize the fistula. And so the recommendation is to create these fistulas when they're in stage 4 with a need to have dialysis in the 6 months period before dialysis onset. The upper extremity arterial venous anatomy needs to be suitable for fistula creation, and if they are, the fistula needs to be created as soon as possible. If the venous outflow in particular is unsuitable for fistula creation, and prosthetic, meaning PTFE graft fistulas are planned, the recommendation is to hold off until just before dialysis, about 3 to 6 weeks before start. That's a little bit of a hard one to figure out, because it's really difficult to predict exactly when someone will go on dialysis, but it requires close coordination with your nephrologist to get that one right. And the patients need to be educated on the risks of catheters. What are the risks of catheters? It's infections, and then these are typically life-threatening infections with bloodborne sepsis, and at a late stage, endocarditis, and those are the consequences of leaving catheters too long. The other consequence is that the veins close around these catheters. There is constant contact between the catheter and the intima, resulting in fibrosis, fibrin formation around the catheters, and eventual closure of the veins. And these venous strictures are typically very difficult to treat, especially if the catheter is their only means of access. And so oftentimes the catheters will take priority over the patency of these veins. The end stage of this is venous insufficiency of the arms and superior vena cava syndrome. Superior vena cava syndrome is a terrible complication of central venous obstruction of the upper torso. And can result in death. It's basically venous insufficiency of the head and neck, and resulting in airway obstruction, headaches, hemorrhage, stroke, and in my mind, it becomes a surgical urgency / emergency when people show up with SVC syndrome crisis. The arms can also get just as dilated and diseased as the leg, and at a late stage, venous hypertension of the arms can result in ulceration and severe dysfunction, particularly when it involves the hands. And so these fistulas are very important because they let you avoid it by avoiding the central venous catheter. The pre-op ultrasound is a very important tool for determining success. The veins need to be over 3 millimeters. There needs to be central venous patency. The pre-op ultrasound doesn't necessarily show it, but can predict it based on flow parameters, respirophasic variation and flows in the subclavian veins, which can be visualized. Implies that the channel is open all the way to the right heart. The arterial anatomy, it's important to elucidate, in particular, atherosclerotic disease and calcified plaque at the intended inflow site. If there's a lot of obstructive disease at the brachial artery at the elbow, it's probably best avoided in that patients who develop Steele syndrome, this kind of obstructive disease predisposes them to Steele syndrome. Patients with high bifurcation, it's important to get that because oftentimes if you just embark on surgery and then find that your intended artery constricts down to less than a millimeter, and you look around and you realize that you've dissected out the ulnar artery, and in fact the radial artery is right next to it, and the bifurcation of the brachial artery is high. You want to know that beforehand. And you want the arterial diameter to be over 1.5 millimeters, no matter where you take the inflow. So if you're taking the snuff box branch of the radial artery, you still want it to be over a millimeter and a half to take as inflow for a breccia semina fistula. Want the brachial artery to be a bit larger. The choice of cephalic, basilic, brachial vein in that order, and use of non-dominant arm first, non-dominant forearms, and then arms. And once the veins are used up, you go to grafts. So that's the strategy here. AV access is placed as far distally in the upper extremity as possible to preserve proximal sites for future access. These patients will live for decades on dialysis, and they need stable fistulas that last decades. And so you want to use up all the vein that they have. And if they have good cephalic vein in the forearm, that should be the first site of access. And that can be marched up as those veins degrade with multiple access. When possible, autogenous AV access should be considered before prosthetic access. That's the DOQI, D-O-Q-I guidelines, central tenet of fistula first. These autogenous access configurations should include, in order of preference, the use of direct AV anastomoses, venous transpositions, translocations, and the upper extremity access sites are used first, with the non-dominant arm given preference of the dominant arm. Lower extremity and body wall access sites are used only after upper extremity access sites have been exhausted. So if the arm veins are all used up, you can then go to torso-based fistulas, for example, a axillo-jugular AV graft fistula mapped and tunneled on the chest wall, a femoral saphenous fistula on the thigh. Those all come as third choices. And again, even before dialysis or during dialysis, if the patient is a suitable candidate, they should go for transplantation, which is the most cost-effective way of treating renal failure. So the factors that affect fistula patency: small vessels or reduced distensibility of the veins negatively affect patency. The early referral for AV fistula, pre-op mapping, use of vascular staples and intraoperative flow measurements to guide treatment tend to improve patencies. Speaking of the vascular staples, those refer to various clip devices that essentially form a interrupted anastomosis versus a running anastomosis. A technical consideration that you can look up. The interrupted anastomosis does allow for growth and distensibility during the cardiac cycle. The medical adjuvant therapies, the various different blood thinners, do not seem to affect patency. The one thing I would say, though, is that if a patient has thrombosis of a fistula, especially early, technically pristine fistula, a hypercoagulability workup is a reasonable step. And anticoagulation is a reasonable step once you've restored patency to that fistula. Timing of cannulations before 14 days reduces patency. I think that's a silly one. All these fistulas require some degree of maturation. The grafts, the early access grafts can be accessed within a day or two, but typically I make people wait a week on those. But the plain old PTFE grafts, I have patients wait about 6 weeks. The fistulas, we generally wait 6 to 8 weeks at the earliest, typically longer if they are not yet on dialysis. What is a good fistula? There's actually criteria for that. You can see a good fistula. The fistula is visible from across the room, and that the reason why is that the least capable dialysis access nurse has to be able to put a needle into it and then decannulate it and get the bleeding to stop. So the fistula needs to be superficial when the patient is supine. It can't be tucked away immediately, and so that's why we transpose basilic veins. The cephalic vein is in the perfect position. And you need 15 centimeters length of straight, longitudinally oriented superficial fistula for most dialysis centers to be accepting of it as an access point. The fistula needs to be less than 5 millimeters deep under the skin. Any deeper, the dialysis centers have difficulty securing the fistula and getting needle access into it. If the fistula moves too much, they won't access it. And at the end, if the fistula doesn't stop bleeding easily, they will send your fistula back. That is also a strategy for following these fistulas, in that some practitioners never follow fistulas, but rather only see fistulas that are no longer functioning well. So the maintenance strategies involve wait and see versus regular examination. The examination involves feeling for bruit and thrill versus pulsations. If you develop a pulsation or lose the thrill, you may be having problems downstream or upstream, respectively, in the fistula. Regular duplex examinations does not appear to significantly improve the patency, but rather it seems to increase the rate of reinterventions. Why is that? When you find a stenosis in the fistula, the general idea is then to intervene on it. So the regular duplex examination, according to the literature, seems to increase the number of reinterventions without having a significant impact on the patency rate. Central venous obstructions occur in these patients. These upper central veins are a high traffic area, especially for pacemakers and chronic indwelling catheters. The typical thing is to balloon these. Balloon venoplasty is preferred over stenting, in that stents in the upper venous system do not fare as well as the iliocaval segment in terms of interventions. It probably has to do with the fact that there are probably long periods where the vein is either normally empty of blood and not moving, or have very little flow, because in the upright position, the veins may actually have negative pressure depending on the part of the respiratory cycle. When you have a unilateral outflow obstruction, it is possible to cross the midline with the alternate outflow, for example, crossing to the opposite jugular or axillary vein. Any number of combinations can be imagined. I've started actually embarking on first rib resection in that the central venous obstruction may be due to thoracic outlet compression of the veins, and that's a terrible spot to intervene on. It typically doesn't stay open, and it's an absolutely no-go area in terms of placing a stent. The Hero graft is a newer solution that addresses this particular problem. It's a hybrid of a central tunneled catheter and a graft component that can be either the primary graft or sewn to an already present fistula graft. This hybrid procedure seems to have reasonable intermediate patency and allows for patients to continue getting dialyzed through a fistula that would otherwise have to be taken down. I'm going to finish with this case. So how do we find failure? This patient had a pulsatile fistula. The fistula should never be pulsatile. And that in and of itself should drive a fistulogram to look for causes. This patient was able to dialyze successfully off of that fistula despite the pulsatility, and eventually developed venous hypertension. You can see the bulging varicose veins, the dilated collateral veins, and the swelling in the arm. It turns out this patient has also received repeated venoplasties in the same spot. There's recurrence after balloon venoplasty of that locus. It opens back up, but that little bit of scar tissue is seen, and the external compression is in this general area of the thoracic outlet with the clavicle and the first rib and the muscles causing the anterior scalene muscles causing a triangle of compression. So no matter what you do in the vein, even placing a stent won't keep this area open. Rather, you need to relieve the external compression. So the patient underwent a transaxillary first rib resection, and within a day or two of the rib resection, I took him to the lab for a fistulogram. You can see that the subclavian vein had become occluded, possibly as a sequela of the rib resection. And I was able to easily cross into the central veins and balloon this aggressively. You can see that that little notching is no longer present. The patient remains patent 3 months out. I recently saw him this week in the office, and he was quite happy. Initially, he wasn't because the first rib resection hurt a bit, but with home exercise and physical therapy, he was able to recover all of his function and keep that fistula. So that's the end of the slideshow and my talks. Thank you very much for the opportunity to speak. I strongly encourage you to refer to the references listed as resources for treating these three very different conditions. Thank you and good night.